Okay, so welcome to ACU today to talk to some ex-students, some current students about nursing, midwifery and paramedicine. I'd like to acknowledge, do an acknowledgement of country to begin with. So we acknowledge and pay our respects to the First Peoples, traditional custodians of the lands and waterways on which we gather, the Wurundjeri people, and thank them for their continued hospitality. We also acknowledge elders past and present and thank them for their wisdom and guidance as we walk in their footsteps. My name is Geraldine Ribeiro. I'm a senior lecturer and the Bachelor of Nursing course coordinator in the School of Nursing, Midwifery and Paramedicine. Here I am a registered nurse and I'm a midwife. So what I'm going to do now is thank you again for attending today and acknowledge that we have an online audience as well. We will open the floor up to you to ask questions about what it's like to be a nurse, a midwife and a paramedic today. But first, let me introduce you to our panel, starting with our midwife.
Hello. Hi everyone. Thank you for attending.
Can you give us a brief précis of the course you did and where you work and what you're currently doing?
So my name is Christina. I'm a registered midwife. I studied the Bachelor of Midwifery here at ACU Melbourne, and I graduated in 2014. And I work currently at Eastern Health, Box Hill Hospital as a midwife, and that's where I got my graduate year. So I've been there ever since and have slowly travelled my way through midwifery as a career, and I work now in a caseload model for Eastern Health.
Just so that there's a bit of context, so when nurses and midwives complete their course, they generally do what's known as a graduate nurse program or a graduate midwifery program, which is what, I've forgotten your name.
Christina.
Which is what Christina was referring to. Okay, let's keep moving along.
So my name's Steph. I've been studying at ACU since 2013. So I started off with my Diploma of Nursing and then flicked into the Bachelor of Nursing, completed my graduate year, and now doing my postgrad at ACU, so I've really never left here. I currently work in the intensive care unit at Royal Melbourne, and I also spend a bit of time in theatre at Epworth Richmond. So yeah, pretty busy schedule.
Hi everyone, my name is Thomas. I am a registered nurse. I finished my Bachelor's of Nursing degree back in 2016. Interestingly, I actually didn't get a grad year, so I actually went straight into a war-based nursing environment at the Alfred Hospital. So I started off there, and I am still there, and also currently working at the Royal Melbourne Hospital. And I am currently finishing the rest of my master in clinical nursing here at ACU. Yeah.
Thanks, Thomas.
Hi guys, I'm Yumi. I'm one of the international students. I started here when I was 2016 in ACU. I came all the way from Nepal, and I finished off just this year, last year, 2018. And currently I'm doing my graduate program on Monash Health in Moorabbin Hospital in deep procedure, and I'm going off to colorectal in Dandenong next rotation.
Hi everyone, my name is Richard. I am a paramedic. I finished the Bachelor here in 2016. I took about 9 months off and then got a job with AV. Did my graduate year through 2017 to 2018, and now I've qualified from 2018 to 2019. I worked through my grad year anywhere from Richmond to Frankston to Pakenham, so quite a broad area. We do 4-week blocks at a time, and now I'm based in Beaconsfield.
Thank you. So now I'm going to just start off the questions, so please feel free to indicate that you have a question for one of our panellists or all of our panellists. But I'm going to actually ask you to start talking about what a typical day is in your work life. So we can either go this way or we can go this way, whichever, or whoever would like to answer initially.
Yeah, I'll start. Sure, why not?
Yeah.
A typical day is hard to describe. You only really start at the same place or the same branch, but there's no 2 days I've ever had are the same. You'll start on the clock onto the truck about 7 a.m. You do your equipment checks, all your bag checks, make sure you have everything up to scratch and everything's working right. And if you're lucky enough to not get a job or get a case by that stage, most of the time you probably will get a case if you're working within East or West Metro. And that could just take you anywhere. If you're the closest car to the case, you'll go. So yeah, you'll just do job after job. Some people need to go to hospital, some people won't need to go to hospital. You'll have to make that decision and then hopefully get your meal breaks, hopefully you don't do too much overtime, and then make it back to branch and you'll swap over with the night shift. So that's probably the long and short of it, yeah.
Okay, thanks. Richard? Anyone?
So with me, I'm a graduate nurse, so basically I'm just 4 months off being actually a new nurse, so I'm quite a newbie in the field. So for me, as a graduate nurse, I'll be in the hospital. The place where I work is day procedure, so I'll just be preparing the patients for before surgery, and then I'll bring them back from the procedure, from recovery, and then after that, make sure they're all okay, they're vitally stable, and then just educate them on it, and then just send them home, make sure they're stable enough. And during that time, if I need any help, there's a lot of nurses, senior nurses, you have educators to help you as well. And if you wanted to talk to, you can just talk to in charge as well. So a lot of support for graduate nurses and a lot of learning opportunities. So yeah, that's about it.
Excellent.
Well, I guess my specialty is a bit different from surgical. My specialty is in general medicine. So I won't actually deal with any surgical patients. So I guess my day is more like talking to the patient and trying to find out why you end up in a hospital. We see a lot of chronic conditions that has, I guess, deteriorated enough to become acute sort of presentation. So we're trying to find out why you end up being like this. So a lot of history taking. There's a lot of patient advocacy and education, so you kind of show them, for example, how to use insulin pens, how to monitor your blood glucose levels, and when to get help and who to get help from. Apart from patient education side, I can end up being doing an in-service education. So in-service is like a short brief education to fellow nurses about, say, a new hospital policy has come up, or a new procedures or new techniques that we need to know of, or any updates relating to our current practice. I can be responsible for delivering those modules, or teaching still fellow graduate nurses like her to, I guess, facilitate their learning and their needs to help them achieve what they need to. So, yeah.
Cool. So like I said before, I'm a registered nurse. I work at Royal Melbourne in the ICU. So a typical day starts at 7. Generally in ICU shifts are 12 hours, so 7 till 7:30 p.m. That sounds pretty not great, but it does mean you get more days off. So it has its pros and its cons. Also means that you're looking after in intensive care, you look after the one patient for an entire shift, which is really important because often these patients are the sickest in Victoria. Royal Melbourne's one of 2 trauma centres, so Alfred being one and Royal Melbourne being the other. So we see the sickest of all patients. So if anything in the news, you can guarantee they're at Royal Melbourne. So it needs to be one nurse to one patient, and we work 12-hour shifts so that there is less handover and just one nurse looks after the one patient, and then night shift is 7 p.m. till 7:30 the next morning. So long day, but plenty of breaks, and there's plenty of support around you for when you need to tap out and have a minute to yourself. So handover in the morning at 7 a.m, which goes for about 45 minutes. And you think that that's a long time, but there's a lot of intricacies that you're talking about. So one patient has a lot of monitoring and equipment and numbers that you need to talk about. So you spend that full 45 minutes talking about one person. And then the rest of the day is medications are usually at 8 a.m, so you start off with all of your meds, lots of documentation, so hourly number charting and things like that, lots of documentation. And then it's lots of, taking blood samples every couple of hours to check your patient's levels and check that things are getting better and that they're improving. Then you fit in your breaks, like Richard was saying, you fit in your breaks where you can. So, you generally work with the nurse next to you. So when they're on their break, you generally look after their patient for that time. So you can sometimes be looking after 2 critically unwell patients for, sort of a half-hour period. So that's pretty daunting. But and then tap out at 7:30 and get some rest and do it all again the next day.
And the life of a midwife.
Yeah, so very different to the rest of the panel. I work with well, healthy women who are in probably one of the only times in their life where they will be childbearing age and they'll be healthy and they make babies and they push them out. And so a typical day for me is a mixture, kind of like Richard used. It depends on the workflow and what's happening. So I run a clinic once a week and I see the same women throughout their pregnancy and facilitate antenatal care. Check their blood pressure, feel their belly, make sure their baby is growing, have a listen to the heart rate, and talk about labour and birth and postnatal period. And then, my day might flip really quickly. I'll get a phone call, somebody's in labour, and I'll attend to their labour care in birth suite. And I work in a model of care that means my work is quite fluid and it's dependent on the specific women in my caseload. So I don't do shift work, I don't kind of clock in and clock out. I work a 24/7 roster, 10 days in a row, and then I have 4 days off. So the work comes in ebbs and flows. Sometimes there is really minimal amount of clinical work that I'm doing, and I'm doing a lot of administration, following up ultrasounds and checking blood results. And then other days there are 2 or 3 babies born in the same 12 hours. So it's cool. Then I might also do some postnatal care on the ward. So I just go in whenever suits the woman, and then I might also attend a home visit. So my day can be very random and sporadic, but also filled with lots of goodness, checking babies and checking mums.
Thank you. So as you can see, typical days vary across the 3 probably most prominent healthcare professions. Okay, so we do work in a multidisciplinary team in the health sector. So along with nurses and midwives and paramedics, there are other professions with whom we collaborate on patient care depending on where we actually work. So the beauty about our careers is that it can take you wherever you want. It can give you a different perspective every day of the week that you weren't expecting. Or if you're lucky, you might have a day where it's slow and you get your tea break or you get your dinner break. But more often than not, you won't. And I've got to say, as a healthcare professional, we learn to eat very, very quickly. You go to dinner with people who are not nurses, midwives or paramedics or even doctors, and they're all sitting there eating and you're done because there's not a lot of time to eat. But it's such rewarding work. So, now, has anyone got a question? Thank you.
I got your name, but
That's okay.
Christy.
Christy.
If you work 24-hour days and then get 4 days off, how do you get time for personal things, kids, or
Yeah, it's a good question.
or anything?
Yeah, so the program that I work in, it draws a specific type of midwife that often either has 20-something-year-old children or no children at all. It's very difficult to get called in at 2 or 3 in the morning and have a young one in bed. So none of the midwives I work with have young children. The midwives that work on the ward in core team midwifery often can juggle their shift work and their children. When I say 10 days in a row, either end of that 10 days we have a night off. So when we first go on call, we have a night off, and before we finish our on-call stretch, we have the night off. And between our colleagues, we can sort of switch our accrued day off depending on workflow, and if we have a personal dinner or a wedding or something that we need to get to. So yeah, it's demanding, definitely, to say the least. And there is definitely a length of time I think you can work in caseload before you desire your own family or you retire. It's a really specific window. So often midwives that work in caseload either do it for a really long time after they've had their own children, or they do it for a short time, then they have their own babies, and then they go back to cord midwifery. So it's, yeah.
Thanks, Christine.
That's okay.
We don't want to give you the wrong impression. We do get some time off.
Absolutely.
We don't spend all of our, when I'm saying we, I do, what's the word, empathise, because I'm beyond that now, being here. But yeah, there is time off, and there is time to regroup and recharge, because that's equally as important as being there caring for our patients. Anybody have another question okay? Sorry, I saw you first. Off you go.
A question for Richard. I work in the plumbing industry now for the past 8 years, and obviously you transition from an apprentice first year, second year through to a tradesman. How does it work in terms of a paramedic? Obviously you go through your placement and then end up ideally being employed. Do you work under somebody with a certain experience for a certain amount of time, or how does that work?
Yeah, it will vary. Sorry, it will vary from state to state. I went through the Victorian system, so essentially you'll do your 3 years of the bachelor degree, and that should hopefully teach you a good amount of what you need to know, along with your placements, and they'll set you up for the job. Then once you apply to the service, you'll go through their criteria of what they require you to be able to do. Different services will work under what's like a different scope of practice, so what the government or the Department of Health allows their paramedics to do. And then if you've been successful and you do the graduate year with the service, basically you'll do 4-week blocks, and you might do it all at the one branch. So it's convenient if you live locally to your branch. Sometimes you might go rural, maybe to Ballarat, maybe to Shepparton, doesn't matter wherever, or you might be in metro. And then each 4-week blocks, there's certain criteria you have to be able to meet and perform and do. You'll work with someone who's either a clinical instructor or a paramedic educator, so they're just higher tier paramedics with many more years experience, and then hopefully you can learn off them. And then at the end, I think it's changed slightly now what you have to achieve by the end of the year, but I had to see what was called a panel, which is it was a whole day assessment with 6 exams, and it's a 100% or fail sort of exam. So it's pretty dicey day. You prepare well up to it, and then hopefully you pass and become qualified.
So theoretically, if you pass all that, all good.
Yeah.
Next year you're working.
So if you
by yourself or with somebody, but
you still work with a partner. But yeah, once you've completed your graduate year, you're guaranteed a position as a qualified. Yeah.
Sure.
Yeah.
Good, thanks, Richard. I'm going to just take a question from an online inquiry now. So Georgia has asked, does every nurse or midwife do the graduate program? And if so, what does it achieve?
It's a good question.
I actually can answer that because I personally didn't do a graduate yet. So it is not a compulsory requirement for any graduate nurses or midwife to complete a graduate year. However, this program is designed to set your success in the industry and the career. So they have very specific programs within, or learning contracts within the program to help you in different directions that you might come across. So for example, your program has rotations, so it allows you to explore different specialties within the healthcare settings, and hopefully you might find your interests through the rotations. Then you can pursue a further career after your graduate year. For myself, I didn't complete a graduate year, but I was lucky to get employment through a ward unit within the Alfred Health. Then afterwards, I decided that I had enough experience at that specialty that I want to move on to a different area that I'm interested in. But I guess there's no right or wrong answer in this. As long as you get the qualifications, you know where you want to go. I'm sure you can find where you need to practice, but it is not compulsory to have the graduate year.
Yeah, I mean, I can add to that. I did my grad year, so I think it's you sort of can choose either option. When I graduated from my cohort of friends, and you develop lots of contacts at ACU through any university through group projects that you do, so you have a wide variety of nursing friends that you graduate with. And I actually only knew one person that didn't get a grad year after applying. So it's not too difficult, but it's competitive, and there's lots of factors that go into getting a grad year. Personally, I think it's a great idea. It's a great option that it does look like Richard was saying, Thomas was saying that you do get to taste a few different areas. So I rotated through anaesthetics as one of my options, and then also just on a ward for 6 months. So it has its pros and its cons, but it's definitely a good option, and I think most people do a graduate year.
Yep.
Not compulsory though.
Yep. And just to add on to both of colleagues, I'm doing a grad year in Monash right now, and so I get like a bit of a preference, and they try to give me at least one of my preference that I've chosen, so that way I can actually at least know what it is like in a daily basis. Do I want to do it full time? Do I want to do it in a permanent position, or do I just want to keep it part time and then do something as casual, like I can do agency or something? But I think as an international student, for me, personally, was quite tough. Not because just because I couldn't get through, or it was a lot of more steps. But for me, I had like hurdles that I had to overcome. As in, I had to do like certain tests and then meet certain requirements. And but for locals, it's a bit more easier. But I would say if you are up for it and you can commit to a 1 year program, just because they have a support system, which is the thing you need as a newbie anywhere, even when you start your school as well, I would say. So similar thing. And also as a graduate program, right now I'm working in a diabetes center, as I said before, where you just prepare patients for surgery. But actually I also got to get exposed to theater, which is where they perform the surgeries. So right now actually just on Friday I spoke with my other ANUM in the theater, and she said she's more than happy for me to give a job there actually, because even though I wasn't directly working in that area in the theater, actually I'm interested in just because of the exposure I've had. So you kind of indirectly get exposed to other things as well. And then, if you just speak up, and then if you really like the area, the nurses and the in charge, they'll actually be open to, supporting you as a new graduate nurse. So I would say if you're able to go through a graduate program, it would be a good idea.
And the other benefit of a graduate program is that it's a 12-month get-out-of-jail-free card where you can put your hand up and say, I don't know, I'm a baby nurse, I'm a grad. Whereas, Thomas, I don't know if it's the same for you, but just as a straight registered nurse, you can't really say, I'm a grad, don't yell at me.
It was a bit different for me, because I was employed straight as a grade 2 registered nurse, not as a intern or junior nurse. The support that I had was a little bit less than what the graduate nurses would have had, because they would have designated graduate support nurses that float around in different, they have this pot system in each, well I think in different hospitals it's sort of similar, but they have this pot system where a certain number of graduate nurses have 1 or 2 different educators that look after them, so they will float around in the hospital to support them if they have any questions that they might have, or some clinical works that they might have. So I guess that's a good way of getting help to kickstart your career from being in a university to a real life hands-on sort of your job sort of experience. So yeah.
Plus you have like a lot of double checking as well. So, as a transition from student, like when I'm doing my IV medications, giving stuff to the line, actually in university, I've got teachers, my lecturers that I can check with. But in hospital, you get other nurses who's senior, they need to double check with you. So that way you're actually reminding yourself that I'm going to be doing this soon enough, like in next year, or so next month or next month. So it actually gives you a bit of clarity and affirmation as well that you're actually going to that path. But doesn't mean you have to always ask questions to your educators, because they'll be floating around like he said. They'll come by and you'll have debriefs as well. So every month or so, they will gather all the new graduates and they'll talk about how you went. So you can actually learn from other graduates from the same hospital working in different areas as well. Yeah.
I think it's a really individual journey that you take, and when you study health sciences, you don't realise the immense change that will happen to you. I came into the course thinking I'm going to be the best midwife ever. I'm going to work at the Royal Women's. I'm going to smash it out. And I got all my placements at the Royal Women's and I loved it. And then it was a bit of chance when you apply for a graduate year and you work as hard as you can, you volunteer, you expose yourself to everything and anyone that talks about midwifery. And then you find out you don't get the grad year that you wanted. And so for me that was very confronting, because I had done all the work and all the preparation to get my graduate where I wanted it to be. And then it wasn't even at a hospital that I'd been to before. So, but in turn I thought, oh yeah, I'll just do my graduate year, I'll learn what I can, and then I'll go to the Royal Women's. And I've been working at Eastern Health for 4 years, and I love every single person, every single doctor, every single midwife that works there. It's amazing how your perspective changes through not only the degree, but then into the chances that you get when you take that gamble.
Just to put some context around this, so you spend, for all of these courses, 3 years studying, and then you are registered with AHPRA, the Australian Health Practitioners Regulatory Authority, which has their own boards. So there's a nursing and midwifery board, and there's a newly established paramedics board. So all of these people and me are registered, and to work you have to be registered. To be registered you have to complete the course, okay, regardless of where it is, here or elsewhere. Excuse me. So, and then the norm is to go on and do a 12-month graduate nurse program. AV, you don't have a choice, you've got to do it, don't you?
Yeah, definitely.
Whereas with nursing and midwifery, you do have a choice. And you've heard pros and cons for doing a graduate nurse or a graduate midwifery program. Okay, questions?
Say, is it really difficult to get employment as a newly qualified nurse if you don't do a grad program?
Are you asking like whether getting a grad year done is easy to get employment, or?
No.
Following your course, you mean?
Yeah, following the course. Okay. Is it like, if you don't go through the grad program, is it more difficult to get a position, or?
Well, I personally don't agree with that. I'm an example of not getting a grad year done and got a position. It's about your connection. It's about who you, I guess, where you exposed yourself, because you're applying for a job, you're selling yourself to people, so you need to talk to people. You need to know what they're looking for. So not necessarily a cut-off like, you don't have a grad year done, I won't employ you. You have to go through the series of, I guess, selection criteria that match the employer's need. So it depends on the health organisation. They might like to get you an interview, and if they think that you're suitable, they might employ you too. But having a grad year, I guess, gives you that line in your resume saying that I completed a grad year. I have a very structured training post my degree to help me to build my nursing skills. So it does give you a bit more, I guess, employability, but it's not guaranteed. So it depends on person to person. So, but yeah.
The question was, are there opportunities without a grad nurse program? Yeah, and yes, the short answer is yes, there are. Basically what it means is that you need to seek out those opportunities. To do a grad nurse program or a graduate midwifery program, you go through what's known as a computer match system, not dissimilar to what you did when you selected your university. of choice, which, you know, going through the VTAC system. And you rank for hospitals or health services, and then you are generally rewarded with your first choice. Okay, if you don't get that choice, then there are other opportunities. Now, Thomas went through a different system and did a first year out. Okay, the others have gone through a graduate nurse or a graduate midwifery program. So yes, the answer is that there is opportunity. Now, somebody, yes.
Richard,
Yeah.
Yeah. Paramedics don't tend to stay in the job for a very long time. Do you have kind of any idea what, if you do kind of leave the job earlier, do you have any plan of what you do afterwards as such?
If I was gonna leave, I would probably look to nursing. I think I like healthcare. I think the industry is really good. I think having the paramedic background, you get similar sort of, I guess, skills that a nurse would have, and they're somewhat interchangeable. You do work a bit more autonomously as a paramedic, and you sort of got to still make the decisions. But I think healthcare in general is a really good area to get a job in. I think working for people, for the betterment of people, it's a really fulfilling sort of career path. So anything within that realm, I wouldn't mind doing. I think at the moment, the statistic is about 5 to 6 years is the length of most paramedics these days. Whether that's the old school, people stuck around a lot more in their older jobs, and you had guys doing 25, 30 years as a paramedic. Maybe it's a newer generation that, want different opportunities or seek jobs elsewhere, grass is green on the other side sort of thing. It's hard to say, but yeah, it's probably a combination of the work that makes it difficult to go on many years. Yeah.
Also, do you plan on so you can specialise to do MICA or aquatic rescue? Do you plan on doing any of those things? And if so, do you know how difficult it is to?
Yeah, so I'm attempting to set myself up for the MICA course now. You generally have to put in about, if you're doing it quick, you can do it within 5 years as an ALS paramedic, which is the level I'm working at now. Paramedics doesn't necessarily have as many promotional options as nursing would, or nothing. Nursing has a lot more opportunities to move laterally into different areas in medicine that they find more interesting or didn't like, and can move to a different area and use their skills somewhere else. Paramedics, you sort of have to be a bit of a jack of all trades and be able to perform all functions, whether it's for an obstetric patient or a geriatric patient or a little kid or a baby, or you sort of just got to be able to do it all. So that makes it not as easy, but yeah, I think trying to go through the MICA skills and improve yourself academically is one path, yeah.
I just wanted to ask
Christina.
Just a bit more about, you talked about it's caseload midwives,
yes.
And then there's, you said 14, is it 4?
Yeah.
And all hospitals function with both those models?
Most do. So where I work, core midwifery is basically a pool of midwives that work shift work. Right, so there's 3 shifts. There's an AM, a PM, and a night duty. And so they can self-roster or request their roster, 50% of their roster, and they work on the ward, and they work in birth suite, they work in domiciliary or home visiting. And they can rotate through all 3 or choose one to specialise in. And some midwives are more comfortable in birth suite, some midwives are more comfortable in the postnatal ward. But in caseload midwifery, you work your full scope of practice.
Because it's a patient.
Yes.
And when you were talking about 24 hours, you don't mean you work for 24 hours.
No.
It means you're
on call. That's right.
So how does that actually work in terms of how many hours you work?
So we can work a maximum of 12 to 14 hours in a 24-hour period. And so, for example, on a day that I have antenatal clinic, my ability to care for somebody in labour is reduced until I've had a big sleep. So if I am called to a labour in my clinic, which often happens, then I can work a maximum of 12 hours in that day. At about 12 hours, you start to lose your marbles a little, would you say?
Mm.
So then
And you need to hand over.
someone else would have to
Yeah, so
relieve-
then someone from my
relieve
team
you
would relieve me.
if you got to that
Yeah,
point
yes.
in time. But I mean, do you have times where you have a very short sleep in between?
Yes, so if you work a 12 to 14 hour shift, you have
Yeah.
to have a 10-hour break.
You have to have a 10
Yes.
break. Oh, that's okay.
Yeah. So it's
you
pretty
have-
good.
You do at least have enough time to sleep
Yeah.
and eat and-
So in that 10-hour break, you can have breakfast with your mum and
Yeah.
coffee with your boyfriend. You know,
Yeah.
you do make the most of that time.
Yeah.
Yeah.
And then you said after that, being on call, there's a 4-day.
Yeah, a 4-day break.
A
Yeah,
4 days.
and once a month we get an accrued day off, so we have a 5-day break
5-day
once a
break.
month.
Okay, yeah, so there's still quite good breaks.
It's good, and annual leave on top of that.
Yeah.
So, yeah.
As you, Christina has pointed out, it's important that regardless of what your healthcare profession is, that you are alert.
Yeah.
And so therefore the shift work is designed so that you don't actually risk not being alert
Yeah.
sufficiently.
The only thing that doesn't seem to apply for is doctors.
That's
Yeah,
right.
there
yeah.
are. I can't comment on there.
I think they get paid enough to get that.
They have actually improved significantly since when I was training, for example. So
But I guess
they're
you've all got unions as well as for all those
yeah, correct.
parameters.
Yes.
Oh, yeah.
I'm going to ask you a question on behalf of an online person here who's a YouTube user. I'm interested in studying midwifery, but I'm worried I won't have the stomach for birth, blood trauma. Is this something people get used to?
Absolutely. I think, yeah, sorry. There's no other midwives, so I'll answer.
Oh, just me.
Oh, yeah. The idea of taking blood was like so disgusting to me. I don't
Taking
know.
blood?
Yeah, putting a needle in a vein. I was like, well, I don't know if I can do that.
Really? Yeah.
Thankfully, here at ACU we have really great labs. So you do a portion of your training in a synthetic environment where there are fake arms and fake veins and real needles, and yeah, I think the clinical part of it for me is just something that you do get used to it, and you kind of get a thick skin because the actual work is with the women and the families, and so yeah, you do as your skills build. For me, it was like once I got my first vein, then it was a challenge to get the next one, and the gross part of the blood or the mistake disappeared, and I see birth as beautiful. I don't see it as traumatic or disgusting. So yeah, I think the clinical side you build a courage and experience.
It's a good question because every healthcare professional sitting on this panel will say they have something that they absolutely love about the skills that they have and something that they can't tolerate. I can't tolerate vomit or sputum, but I love taking blood.
Everyone has a thing.
So
It's
everyone
so
has
true.
a thing
Some
that
is
they're good
vomit.
at.
Yeah.
And that is their forte. So yeah, you just don't notice it. You don't notice it.
And I think as well, like speaking from a trauma perspective, we see some pretty terrible car accidents, gunshot wounds nowadays, which is unfortunate. And I think family and friends will say, how can you deal with seeing that? But it comes back to your training. You go, oh, I've not done this before. I've not seen that monitor, or I've not. It actually just kick into this. I've never seen, wow.
There is this wow factor. There is.
I think we intuitively as humans, we're interested in things that are a bit weird or a bit, that we don't see often. Yeah.
Okay, question.
Hi, sorry, another one for Christina.
Yes.
Did you do
Ding,
the
ding.
single degree in midwifery?
Yes.
And what are the pros of doing that rather than doing a double degree or a postgrad?
So it's controversial, and you could speak to 20,000 people about this topic because everyone has their own opinion. For me, it was like I didn't want to do nursing because I was scared and fearful of people being ill, and caring for a well, healthy woman was a very different philosophy to doing nursing and midwifery combined. And so I actually applied for all of the courses. I thought, however I'll get there, I need to be a midwife. And so I was willing to do the course and put up with the placement, but ideally I wanted to just get into midwifery. So when I applied for Bachelor of Midwifery and I got a spot, then I was very happy with just doing a degree.
Postgrad, sorry, that's the wrong one. Were you a school leaver or did you do?
Yeah, so I had left school. I finished my BCE and I went and did a contemporary arts degree at Deakin, and then I pretended to be a photographer for quite a few years. I was always fascinated by the pregnant woman and how a woman can grow a baby, and somehow that got me into applying for midwifery.
How did you find applying as a mature? Because I'll be applying as a mature student, and I have no idea what to do.
So at the time there was a program called the Early Achievers program, and I applied through that and was guaranteed a spot through that. So it involved community engagement, and but I had other colleagues that were they hadn't finished high school and got a place in Bachelor of Midwifery. So yeah, there's lots of different avenues.
The Early Achievers is an ACU thing, but most universities will have something. Okay, great. Up the back there.
What sort of support do you guys get in terms if there's any traumatic experiences, like if there is a death of a mother or a child, or a really sick patient that passed, like what kind of support do you guys get for like overcoming those traumatizing events?
It's a good question, and it's about the support that the health professionals get in the face of challenging situations like trauma or death or
I guess my experience probably can relate to that. I was lucky or unlucky enough to participate in caring for some of the patients that had gone through the Burke Street car accident thing. So within the hospital they have an automatic peer support system that they will activate when such traumatic event happens. And on the day it was actually a COBRAM, which is a external incident code that was called. So all of the people who are on the floor directly or indirectly involved in the incident management or had some sort of connection to it are all contacted by the peer support, which is an external organisation, if you like, just to make sure that we are okay. And everyone has to go through compulsory sort of debriefing sessions to make sure that we're all fine. And often things like this happen, you don't realise it until a few days, sometimes weeks after. There's always a place that you can refer back to for any support that you might need. So, yeah.
In my hospital as well, even before I entered the grad program, you have like 2 or 1 day of a whole day session where you attend and they go through what is coming up as a graduate nurse and what support do you have, including emotional support as well. Just because you're transitioning and you can't play half the day, you got to work half the day and decide half the day to work or do something. So basically you have these links, and there are people who come around as well if you needed to talk to. Sometimes they have your educators or your in charge, they post, they have some leaflets or something like that around in the tea room or around the ward. So I think it's our responsibility or your own responsibility as a individual just to reach out for that as well. Just because there can only be so many things that can actually be there out to help you, but if you're not willing to go and grab it, I think you should help yourself at that time as well. But surround yourself with people who can actually help and support you as well. And I think as a student, because I also went off like straight from high school to, actually I did bachelor in social work for a while, and then I started my nursing. So during that time, what I learned is that there should be a positive way of learning to have a coping mechanism, like say music or sports or even other things that everyone has different. So I think it's a good idea to, along with having other supports as well, but having a thing you can do for yourself at that moment is also great.
Obviously, peers are a good support, but every healthcare service and every healthcare professional will have access to a formal service that is either counselling or some form of support service these days. Okay, I was going to say, any more questions? There you go.
I was quite surprised to hear how the career in the last 5-6 years. I'm wondering, did you get enough support in your area, and why the career is so short?
In what way do you mean support? In what regard do you think?
Whereas like trauma.
Yeah.
Because I'm wondering that when you do go in a case, often you don't know what you will.
Yeah, that's absolutely right. Sometimes, depending on the case, it might have only happened a minute ago or 5 minutes ago, so there's very limited information that you're receiving, and sometimes the information's wrong as well. So what you've mentally prepared for in the last 3 to 4 minutes wasn't exactly right. And I think in a mental health capacity, I think ambulance or AV, I can speak for, has gone much better with that. It's very, very obvious that management cares about well-being, and they're often talking about it. If we go to a case that was quite significant, maybe it made the news, or I guess they get flagged, these cases, these quite large cases or quite significant cases will get flagged, whether by the dispatcher or the call taker at the time it happens. And then you go to the case, you do the best job you can, do what you need to do, and then whatever happens with the patient after that, XYZ, maybe they deceased on scene or made to hospital, depending on the case. It's in a manner you'll debrief with your partner. There's a peer support group that'll call you pretty much within the hour after you getting back home. They'll take you out of service as well, so you can have the rest of the day off if you wish that to be the case as well. And their ongoing psychological support, we get four free sessions per year with a psychiatrist or a psychologist that are contracted to Ambulance Victoria, and then any other support that we need as well with that, if they think maybe we're at risk or anything else really ongoing. There's a good peer support network internally with AV run by paramedics that will sort of offer mental health support as well. So there's a couple of different avenues. I think that short longevity of a paramedic is more due to just on a personal opinion. I think it's just that the shift work is difficult. It's 4 days on, 4 days off. Most branches will do a day, afternoon and night. So it's 10 hour, 12 hour, and then 14 hour night. That really, it's difficult to get your head around that a little bit. Names of days don't really make sense anymore. You just think, what day is day one, and when do I need to be back at work? So if you have kids or relationships or footy teams or soccer teams that you're involved in, that becomes quite difficult. You have to really commit to get that into your schedule. And there are ways around it, but it just takes a lot more effort. So if those are big areas of your interest for you, then it'll make it challenging. Yeah.
Okay, I'm just going to take the last question from online, and then we'll... So the question is from Chloe. What's the difference between the double degree in nursing paramedics rather than just paramedics? I'll answer the first bit, and then you can talk about whether you see it as a advantage or not.
Yep.
So when you do a double degree in nursing paramedics, basically you are qualified to be a nurse or a paramedic, and you are registered as both with AHPRA. Now,
if I was to look back, I think a double degree as a nursing paramedic is a really advantageous thing. I think looking back, I can really appreciate, I think, a nursing graduate year and the nursing experience is really, really valuable, rather than just doing the straight paramedic degree. It can be done. I've done it, and many, many people have done it as well, but the road is a lot steeper. The learning curve is quite high. You could be 5 days in as a graduate paramedic and go to the biggest job of your career You could be 2 months in and go to the second biggest job of your career. Like, nothing really prepares you for that. Or you could do your whole grad year and maybe only see a couple of real sick patients, and then down the track you're going to really sick people. So I think nursing is really much more supportive. They can, and much more encouraging. You have a more closer team who can really assist and answer your questions. But unfortunately, the work of paramedicine is so diverse that you just don't know what's going to happen. So I think having the nursing skills beforehand is really, really useful, and you don't have to worry so much. And if you want to come to paramedics, then I think you'll find it a bit easier.
Okay, we'll go up there.
Just with the double degree, so say if you were to do it and you went on to do paramedicine for 5 or 6 years, and then you wanted to switch over to nursing, is it like relatively easy to just go straight into nursing, or how's that process work?
Okay,
Maybe
so
both answers.
Yeah.
I think if you did like 5 years of paramedic work, I think the transition wouldn't be too difficult. But whether you wanted to, if you wanted to divide your time evenly between the two divisions, or you wanted to work full-time as a paramedic and pick up casual shifts as a nurse, or vice versa, full-time as a nurse and some casual shifts, it's not too hard. I think, it's each their own, I guess, a little bit, how much you want to commit.
There is a regulation by the Nursing and Midwifery Board of Australia where you have to be working as a nurse to maintain your registration. And if you don't do that for 5 years, then you need to do a refresher. So if you have a double degree and you focus just on paramedicine and don't work as a nurse for 5 years, then it's something that you need to consider. To maintain our registration, we have to be working.
What's the refresher course? Is it just like a year? Or?
I'm not able to comment. There's very different ones, and that's governed by the Nursing and Midwifery Board of Australia. Go on.
When you study a course, do you just work with people doing the same course as you? Or do you work with like everyone doing the subject bio or something at the same lecture? Or do you just work with the people you're studying with? Course?
At ACU, we have nursing units, midwifery units, paramedicine units, and multidisciplinary units. So there are some units where these guys will all be in the same class together, and there are other units where they're with their own discipline. And I'm pretty sure it's like that at most other universities. They have both, a mixture of both. I shouldn't have answered that question, I should have let you.
Yeah.
From what I remember, I think that was about the same.
Sounds good.
And what did you think of that, working with different healthcare professionals?
I think you get to see a bit of their perspective of what their discipline is like. I guess for me, I did my first year study in nursing with some physio OT students, and you get to talk to them like, oh, what's your degree like? Like, what do you do? Like, how is it different? I guess you get the understanding of what they do. And it kind of helps you too when you finish your degree and further down the track when you need to interact with them, you kind of understand, oh, these people are to help them with, their mobilities or their functioning and whatever. So it does help.
Yeah, and later on the track, when you're out there in the real profession, you're going to be working with physiotherapists, you're going to be working with paramedics, nurses like yourself, and then I think it just gets easier. It's just like training you up to work in that environment. You don't necessarily get to choose, but you get to choose who you are when you're working. And I guess paramedic might focus more on like acute kind of cases and have like more knowledge regarding if I'm working in hospital, I might have like more skills regarding just a skill set that's going to be specialized in hospital more. So I guess you get to share your skill sets as well early on.
Good, thank you. Now, I only have time for one more question. So I did see that person first, so if you'd like to ask your question.
What's the entry score for nursing?
Okay, differs at different universities. At ACU, for 2019 it was 80.3. For midwifery it was 86, and for paramedicine it was around the same. But I can only speak for ACU. Do we have one final question about career choice? Or?
Okay, thank you very much. I just want to ask, like, when reaching for the double degree or postgraduate degree, like, I'm thinking about I'm not sure if I pronounced properly, but like the nurse anesthetic on, yeah.
Okay, so
So which is once you completed the bachelor degree, like could you tell me about that program and stuff? Yeah.
okay, I might actually get you to speak to these guys after about that specifically, because Thomas might be able to advise you about or give you some idea about postgrad courses. Okay, I'm going to just close with asking these guys one final question, and that is, what would be the biggest myth or misconception about your role or industry, do you think?
Big question.
I'm happy to
Yes?
go. I think about my specific role, and I think the public, maybe the biggest myth with the public is probably that we save lives every single day. And I think there's probably a couple of different media platforms out there that are maybe showcasing that a little bit, and it's not necessarily that you are saving a life, because if you're ever doing that, that's a really, really unwell person. A lot of the time, what the public believe is a 000 call, and an emergency to them may not necessarily be an emergency to you or an emergency to the ambulance service. But of course, we're more than happy to go and have a chat and figure out what's going on and how we can help you. But yeah, not every single day as a paramedic you're going to emergencies, but it might just be something like a poor old Nana's fallen over and she can't get up, and then you find out she has a fever and she's feeling a bit weak, and that's why, which is more than okay, and that's exactly what sometimes the service really needs to be there for, because there's no one else that these people can call that's going to come in a timely fashion. Brothers and sisters might be 8 hours away, or kids might be 10 hours away. So yeah, I think that's probably one misconception I think that's out there.
What about nursing?
Yeah, I think for nursing, a big misconception is that we spend all day bathing patients or feeding patients. I don't know, like the things that my family and friends think I do versus what I actually do. And I think a big misconception is that we are under the guidance of doctors, which is often very, very untrue. So Royal Melbourne specifically is a teaching hospital, so often the nurses are the most senior people there, and often a doctor will say, we'll pull up blood reports and say their potassium's this, and they'll say, what do you want me to do about it? What would you like? So often we're the ones directing care and giving orders to very junior doctors and saying, and junior doctors may say, those numbers mean nothing, and we'll fight and say, no, this patient's deteriorating, or. So I think that's a big misconception, is that we are the doctor's assistants. It's often the other way around.
And midwifery?
I think one of the biggest myths is that midwives cuddle babies all day. That sounds nice. It does sound nice. And there is definitely a link between midwives becoming mothers, or have become a mother and then decided to be a midwife. But it's really our practice is really about working with women, and the baby comes with that, and often much later down the piece. And you might get a little cuddle, but we don't spend all day and all night cuddling babies.
What a shame.
What a shame.
You will never ever regret a career in health, because it'll take you travelling, it'll take you into other aspects of other jobs that you may not have considered. It's a rewarding career, and we'd ask that you consider it very much so. You're here, so obviously you're interested in a career in health, and I think the panel would agree with me when I say that it is a qualification that you would never regret having. So I thank you for attending, and I hope you'll consider a career in healthcare.
If anyone wants to stick around